Thank you for inviting us to give this talk. We're always thrilled to talk to our nursing colleagues. The 21st Century Cures Act is going to make things a lot different starting April 5th. And we are going to talk about this and about some other things, sort of from our perspective of working for the past decade in advocating for more open information for patients. Suzanne, Leveille, and I know a lot about OpenNotes. We've looked very carefully at some of the regulations that are published by the feds about the 21st Century Cures Act and the rule. But we are not attorneys. We do not work in the compliance department. So please don't take any of this as legal advice. I'm going to start by talking about the Cures Act, and then a little about OpenNotes. And then Suzanne will pick up and talk about some work we've done with nurses in OpenNotes. And I think that we will have a good amount of time at the end for questions and discussion. You know, neither of us is in a clinical setting anymore. So we are really interested in hearing your perspectives and feedback on all of this. Whoops. So I think it's informative and actually kind of interesting to look back and think about how we got here. Things started really with HIPAA, which was a federal law that created national standards. Basically, most importantly, HIPAA protected sensitive patient information from being disclosed without the patient's knowledge or consent. It was and is enforced by the Office of Civil Rights and Health and Human Services. And as we all know, it allowed patients to obtain a copy of their medical record by submitting a formal request. Now, this is 1996, so this is all about paper. The next big move was in the HITECH Act, which stands for Health Information Technology for Economic and Clinical Health. This was part of the American Recovery and Reinvestment Act, which was this gigantic infrastructure package that was trying to get the economy started after the 2008 recession. Now, if you think back to 2009, before this act, only 10% of hospitals in America had EHRs. And what HITECH did was set up a lot of money as incentives for providers to install EHRs. It also changed the rules for patients getting access to their data, because from that point on, if a provider had an EHR, the patient could demand an electronic copy of their record, not just a paper copy. Now, also under HITECH, the Office of the National Coordinator of HIT, which already existed, ONC was set up as the oversight body for all of this. And this was the period of time, 2009 to 2015, when meaningful use really got off the ground. Remember when the standards just kept going up gradually over years to make EHRs more meaningful. Then in 2016, the 21st Century Cures Act passed, and then last year this rule was published, which basically establishes the rules for implementing the act. Now, the act itself passed with broad bipartisan support, sort of an interesting topic today, because the Congress was Republican and President Obama was, of course, a Democrat. The overarching goal of this entire act was to advance medical innovation. The main part of it, this is a 300-page act, the main part of it accelerates development and review of new drugs and devices. For example, it asks people to modernize clinical trial designs, and it establishes some new institutes to coordinate activities in major diseases. For example, putting drug, biologic, and device development all in the same agency. So it's quite forward thinking. But it also has some provisions to drive the electronic access, exchange, and use of health information. And it really leverages EHRs, which now are, widespread, to improve care. And of course, this is the part we're interested in. Now, the key HIT provisions in this act, first of all, overall, it gives patients more control of their medical record and gives them access to it. And there's language about they'll have this access without delay or special effort. And the intent is that patients will have data that is quote unquote easy to understand, secure, and updated automatically. And the whole idea is that patient access is electronic and automated to the greatest extent possible. It also promotes interoperability because the intent is that exchange among different kinds of EHRs, disparate EHRs, will be seamless. And it also, to promote this idea of seamlessness, it mandates new standards. Two of them are really important. One is that there's a standard clinical data set, which is updated from an old one called the USCDI, which we'll get into. That is data that everyone has to exchange. And then it also mandates use of FHIR standards, which are internet standards for exchange. And FHIR is really going to come into play down the road with apps for example, phones and computers, and also apps that institutions may use. The Act defines and prohibits information blocking. And again, it makes ONC the federal presence in developing and regulating these health IT standards. Now, the intended result of all this kind of writ large is that it's going to it's for both providers and for patients. Health data is supposed to be used in new ways, and it's going to be part of a whole new app ecosystem. Now, right now, patients are viewing all this information in portals, and this isn't going to change tomorrow, but eventually apps will allow both patients and providers a lot more functionality. So what this means for patients, they can now access their chart in modern ways, because eventually they're going to be able to download their information from providers into their apps on their smartphones or whatever. They'll be able to get all of their electronic health information, both structured and unstructured, at no cost, on demand. Now, the idea is that this app ecosystem is is sort of, sort of fun to think about. I mean, remember when smartphones first came out and they had a very small number of apps, and the whole app ecosystem just blossomed. And now, of course, there are thousands. So eventually we should see disease-specific apps, for example, that offer education, progress metrics, maybe connections to community support. There will be new functionalities for patients that, we probably can't even imagine. There's another part of this, also as part of the Cures Act. CMS is required to show user-friendly information about quality and price transparency. So theoretically, patients should be able to compare prices from provider to provider, for example, and really shop for the best care for themselves. So, this is certainly the biggest change since HIPAA, and really it is a huge advance for patients. I really think if it weren't for this pandemic, this would be getting a lot more attention in the media, for example. Now, on the clinician and hospital side, there will be standard APIs. This is part of the FHIR exchange requirements. Standardized APIs, standardized data sets. And the idea is that most patient requests for information will be automated because they're standardized. So things are set up once, and then the individual requests are easy and inexpensive. There's language in some of the, on some of the federal website about, quote, a vibrant competitive marketplace for clinicians to select apps as well as patients. And there are some things for HIT developers too, parens, vendors, and other developers, with lower costs from all these standards. And there are also some new protections for intellectual property. So the timeline is here. ONC and CMS published proposed rules in 2019. There was a long public comment period. The Office of Management and Budget reviewed them. And then last March, this final rule was released. April 5th coming up is the date when the information blocking requirements go into effect for the standardized data set. Then about a year and a half from now, information blocking will apply to all electronic health information. And then shortly after that, there's a requirement for rolling out these API functionalities where patients, for example, can download their information. Now let's look at the US CDI. I'm sure all of you have seen this. These are the data that are to be exchanged with patients and with other providers. The April 5th date applies to these data elements. This is updated from what used to be the Common Clinical Data Set, the CCDS. And this is the United States Clinical Data for Interoperability is what that stands for. So there are some new pieces here, and I'll just draw your attention to a few of them. For example, now the data set requires reactions to allergies, not just that there is an allergy. There are some new vital signs. There are some new demographics, which the point of those being that it'll make patient matching easier. than the shorter set of demographics that we used to have. When providers are exchanging information, it should be much safer for patients. And then there's this whole category of notes, which is completely new, and we'll come back to that. I want you to note there's no, oh no, never mind, that's a mistake. Okay, and now getting into information blocking. So here's the definition. This is a practice that's likely to interfere with access, exchange, or use of EHI. This is a serious thing. It can, the rule, I believe it's the law actually, that provides for penalties up to $1 million per infraction. And these apply to those data elements. Now, there are some exceptions. There are 8 exceptions, which I will show you in a minute. And the way the exceptions work, they're spelled out in a lot of detail. And if the criteria are met, an action cannot be considered information blocking. Otherwise, if a situation doesn't quite meet those details, it may be information blocking, not necessarily, but it may be. And these are the exceptions. I suspect you have seen these too. I will just make a few comments. The first 2, especially to us as nurses, I think, make complete sense. These, you want to prevent harm to the patient or to another person, and you want to protect an individual's privacy. So these really allow clinical judgment to withhold or delay information for a particular patient. The word harm here is defined as physical harm. And we can easily think of sensitive situations that would, fall under these categories, some situations that involve abuse or neglect, infidelity, private information about somebody that's not the patient, somebody else. These are not blanket delays. They're patient specific. They have to be done patient by patient. And these also defer to state laws. I'm sure this is very complex. I don't really know any specifics about that, but they make a point of saying these defer to local laws. Also on this list, infeasibility refers to situations where, the provider doesn't have the necessary technology, they don't have access to the data, they don't have legal rights to the data. It's just infeasible to provide the information the patient's requesting. And a provider is definitely allowed, for example, downtime for maintenance to keep systems running. There are some other exceptions for what are called fulfillment exceptions, which involve certain fees or licensing and so forth. Now, these are, I'm sure we'll get into this in the discussion. I will just comment by saying that theoretically, this all starts on April 5th. Our kind of observation is that organizations are talking about these a lot, trying to figure out exactly what they're going to do with some of this. And what what I kind of expect is that this will start April 5th and then situations will evolve as people try things. And I mean, who knows where it will all end up. I know some organizations are talking about, for example, opening things up going forward, and then patients have to request things that are before April 5th, which they'll get, but they won't be automatically on websites and so forth. These exceptions are very detailed. I will say that there is an excellent FAQ on the ONC website about these exceptions. Now, there is a way, a very easy way for patients to lodge complaints. This is from the ONC website. And if you click on that link, it takes you to a form, goes directly to ONC. It allows free text description of what you want, what you request and you can't get. You can upload things, you can upload screenshots or documents, whatever. And this can be anonymous. So, but it is relatively straightforward for patients to use. Now, let's go back to notes. Of course, we immodestly think that, of course, this is the most important part of the whole thing. There are 8 kinds of notes that are specified. They're all familiar if you look at that list. Notes can include structured and unstructured data, history, review of systems, physical data, plan of care, evaluation of that plan, patient teaching, or other relevant data. Psychotherapy notes are actually excluded, but if and only if they are separate from the rest of the medical record. Otherwise, they have to be open. And while I'm on the topic of mental health, you can exclude psychotherapy notes, which are notes about a conversation, but you cannot block other mental health information like diagnoses or medications or even appointment dates, for example. Notice that these, there's no specification of who writes these notes. It really is all clinicians, or where the notes are generated. For example, discharge summaries are obviously inpatient notes. Progress notes can be anywhere, or when the note was generated. Now, this suggests that all electronic notes should be open, although this is one of the areas where I do hear organizations talking about this idea of only opening going forward, and I don't know where it'll end up. Now, our experience with OpenNotes is almost entirely with ambulatory progress notes, and those are, of course, tied to an ambulatory encounter. But those could be inpatient notes, and I expect, or I hope, that there may be some attendees on this call who already have some experience with inpatient open notes, because we do not have that experience. All right, let's shift now to OpenNotes. Once again, I want to put it in some historical context before moving on to nurses and OpenNotes. OpenNotes started in 2010. Now, I'm going to ask you to think back again. Amazon had set up its first website in 1995 for books. So we're already in 2010, 15 years into e-commerce kind of taking off. Banking and personal finance are going online. like crazy. The world is definitely digitizing, but as we all know, healthcare was one of the last ones to the party. And remember also that high tech was implemented in 2009. Before then, only 10% of hospitals had EHRs, but they were largely large institutions, and many of them had patient portals, which showed patients allergies, medications, sometimes lab results, and the really adventuresome ones had doctor-patient email, although that was contentious. So we basically started thinking about why couldn't patient portals be like online banking? You know, it's your money, it's your medical record. Why couldn't people have complete secure access? HIPAA gave you the right to see the record, but you had to ask, you had to pay, you had to wait. So we decided the most important thing for patients to have access to was, at least to start, was ambulatory notes. So we convinced the Robert Wood Johnson Foundation to give us a grant to fund a pilot. It was a small pilot. We had volunteer primary care doctors. We had a rural and a safety net institution in addition to BIDMC. As I mentioned, looking at notes was already legal. And this project was basically very simple. The notes were already electronic. We opened them to the portal, and we basically announced it. We sent the eligible patients a note saying we're starting. You'll be able to look at your notes. We basically announced it and turned it on. We sent them notifications when a new note was available. And we evaluated it after 12 months. And basically the PCPs were very nervous, but they were fine. And after the study, none of them stopped. Patients were wildly enthusiastic. 99% wanted to continue. And all of the, all three sites well, this paper was in 2012. By 2014, they had all expanded across their ambulatory clinics. So based on that kind of compelling story, we obtained new funding. And now this new funding had a new mandate, which was to spread this idea. We had a goal of 50 million patients to implement OpenNotes for 50 million patients. And we spent several years in all kinds of advocacy. We gave talks, we wrote papers, we talked with journalists, we organized consortia, we started doing all kinds of social media. And we also testified a few times when ONC was thinking about whether OpenNotes should be part of the US CDI. So by December of last year, we actually reached our goal. We had 53 million people. Now, that isn't to say that everything is perfect. We've learned a lot throughout all of this. And we did a large clinician survey about 3 years ago, and about a third of them, this is all clinicians, not just doctors, were saying they did spend somewhat more time on documentation, although they agreed that it gets faster with time. And they also admitted that some of it was teaching themselves better habits, like not using pejorative language, not using too many acronyms, and trying to not use copy and paste. They all said it gets easier. Clinicians have always been really worried the patients would be confused or worried by the notes they wrote. And after a decade and a lot of experience with patients, including big surveys, there are a small number, but it's a very small number. Clinicians want to be able to exercise clinical judgment to avoid patient harm, very much like we were talking about. And it seems like this exception does provide for that. But I will say, even before this rule, what we found was and this was institution after institution would start out with, 2 or 3% of notes being held back by clinicians. But after a year or so of experience with it, that usually cut way back to way less than 1%. So, so people get used to it. Clinicians always also worry about trivial requests to change notes. We don't know of any place that has ever experienced a big increase in amendments. And we have done some studies of patient safety and patients finding errors in their notes. And by and large, they really do appreciate the difference between important and trivial mistakes. I will say the most common mistake that patients bring up, and we are glad that they do, is that they find mistakes in their medication list. But in the end, after several years' experience, clinicians generally do support OpenNotes and would recommend it to their colleagues. We feel like this is going to be just like patient-doctor email. It's contentious at the beginning, but eventually it just becomes part of your work life. Now, we have done part of this last grant, and where we were paid to be advocates. We also had funding to look at some new areas, and I'm going to kind of gloss over these, but I do want to put them out there. Patients tell us that reading notes is incredibly important to their understanding their medications. Like 2/3 of patients in our last big survey of about 30,000 patients, 2/3 of the patients who took medication said that reading their notes was very important in understanding their medications. And 1 out of 7 of them said that as a result of reading their notes, they're more likely to take their meds as prescribed. Care partners are definitely a beneficiary of OpenNotes. They and care partners are very much a part of this. In our last big survey, 40% of patients said that they had shared notes with someone else, and it was usually a friend or family member. And care partners rate the benefits of OpenNotes, for example, understanding the plan of care and remembering what to do, feeling in control. Care partners rate the importance of notes even higher than patients. We have done a couple of pilot studies showing that patients can pick up and also report errors. And in fact, in our last big clinician survey, 1/4 of the clinicians said that a patient had reported an error to them that the clinician thought was important. 1/4. One of my favorite quotes from all these years was a clinician who said, "I feel safer as a result of patients reading my notes because they understand their care. They understand their care. They're only looking at their record, and they can spot errors faster than I can." Patients being able to read their notes, it increases trust in their clinicians. And one thing that we're really happy about is that these benefits are not benefits just for yuppies. These are benefits for people who are marginalized in some way, minorities. They have less education. Patients with less than a high school education consistently rate reading notes as highly important to them. Patients who don't speak English at home, patients who are really sick. You know, the most important thing is that I think that especially for these patients, reading notes seems to build trust in the in our system. So those are the first two parts of this, and I'm now going to turn this over to Suzanne.
I'll go ahead and share my screen. Yeah. So, a picture's worth 1,000 words. So I'm going to start out by presenting a short video from one of our patients that so well captures the summary that Jan just provided about what OpenNotes means to patients. And after this video, then I'll talk about our work studying what nurses think about OpenNotes.
Almost 30 years ago, I was diagnosed.
Sorry.
To the Joslin Diabetes Center, and I met the doctor who is still my endocrinologist there, and he started our first meeting by saying his job was to give me as many tools as possible to manage my illness, but it was really my disease, and it was my decision whether or not I wanted to be in control of my illness. And I just thought that was an absolutely wonderful thing for a doctor to give me. For many years, the diabetes was the only thing that I really had to worry about. But probably maybe 10 or 15 years ago, I found out I had a thyroid issue, which may or may not be related to diabetes, so I have Hashimoto's disease. And then about 3 years ago, was diagnosed with something called hypercomplementaric urticarial vasculitis. Sometimes it's really hard to manage everything with all my health issues. I think the most important thing is just access to information about whether it's a diagnosis or specific tests or what the results are or what my options are going to be. About 5 years ago, I started getting access to notes from my primary care physician, and that really opened up, I think, just a whole new world for me as far as looking at my care and really understanding it. I absolutely believe that having OpenNotes and having access to all my information has changed my relationship with all my providers in a very positive way. It's definitely made me more open to talking with providers and following up with things that I'm not quite sure about that I don't think I would have done had it not been for having the ability to gain access to the notes and other information that's in my health record. I just thought I should mention it to you.
I think again is useful for the overall management of several conditions and definitely improves communication.
I feel like I can trust what the providers are saying, telling me, but that also my providers really trust and listen to what I'm saying. Even though I have a variety of health issues, I still feel like I'm a very healthy person. But I think part of that is because I feel like I own all these health issues. It's just a matter of having more information, more tools, and just owning my health care, owning my illnesses, but more importantly, owning the treatment or the management of that, of the disease.
So I'm going to switch to my slides. Talk a bit about nurses and OpenNotes. As Jan mentioned, a lot of the work we've done has to do with the ambulatory care notes. The inpatient notes will be a whole nother area for research, I'd say, in the coming decade. But these last 10 years, our focus has been on the ambulatory care notes. And more recently, in the survey that she mentioned that we conducted a few years ago, we surveyed all providers. The initial pilot 10 years ago was primary care physicians. So now we have quite a bit of data from our surveys with all clinicians and then also with many patients. So just to bring attention to a statement that the American Academy of Ambulatory Care and Nursing had called for, is that for nurses in ambulatory care, they should be practicing at the top of their license, education, and expertise to affect quality and costs through patient engagement, care coordination, enhanced teamwork, resource reduction, improved access, and quality and outcome improvement. Now, certainly patient engagement and improving access is all about EHR. And it starts with patients and families being engaged. And it's based on developing a trusting relationship and nurses paying attention, of course, to individual patient needs and their skills. But in order to promote better engagement and shared decision-making, patients need information from their electronic health record. And we know from both this example from Ellen Hughes in talking about what it means to patients who have chronic conditions in particular, it really makes all the difference when they can see those notes in black and white and really start to understand their condition and understand what it is that their clinician is looking at and what they're paying attention to in terms of caring for them. And nurses can encourage patients and families to be signing up for these patient internet portals and encouraging them to look at their full records, including the notes. It's important in that process, of course, for nurses to be advising patients that they should be speaking up about errors that they find. I think from our work, we know that patients are identifying errors, although they're not always talking to providers even about errors that they think are important. So it's very important for nurses to have patients read their records and ask questions about what it is. And this is very important for a patient and nurse relationship. So what have we been learning about OpenNotes, and what do nurses think about giving patients access to these office visit notes now that they've tried it and now that the nurses are aware that the patients are trying it? So these were some of the questions that we wanted to ask. We invited over 6,000 clinicians, including over 600 RNs, who had at least one patient who had read at least one office visit note in the previous 12 months. And we asked these clinicians to complete an online survey asking about their attitudes and experiences. We had a number of closed-ended questions, and we also had open-ended questions. From this, we had 193 RNs, or 30% of those that were invited completed the survey. 30% may not sound like a very high number. This was an internet-based survey, so it's actually a pretty good response rate. And the nurses overall had about the same response rate as the doctors and the nurse practitioners and PAs and others who we had surveyed. So we had a pretty good amount of information. So what were some of the outcomes that we were looking at? We wanted to understand their attitudes and their behaviors about OpenNotes. We asked them if they thought OpenNotes was a good idea and whether they thought it was a useful tool for engaging patients in their care? Would they recommend open notes to others? And did they encourage their patients to read their notes? We also had 5 open-ended questions asking them in general, could they talk about their experience? Did they have examples of their experience? Did they have suggestions for how we could improve open notes? So first of all, I wanted to show you some of the results we had on the closed-ended questions, asking nurses if they were aware that their patients had read notes, and 3/4 of them said they had been aware. Of course, we knew that all of them had at least one patient that had read the notes because we had also portal tracking information. And that's how we were able to identify clinicians who had patients that were reading notes. So clearly some of the nurses were not aware that patients were reading their notes. We asked them about whether they thought open notes was a good idea. 80% of them felt open notes was a good idea. We had 75% that felt that they would recommend open notes to colleagues. And 88% thought open notes would be a useful tool for communicating with patients. Now this one point where the bar is not so high has to do with their behavior. And only 37% reported that they had encouraged patients to read open notes. So even though we have really very high positive ratings here on many aspects of open notes, when it came down to actually encouraging patients to get involved in reading their notes, that was another matter altogether. I wanted to summarize some of the other findings that we had. We had looked at a number of demographic factors. One of the things that we discovered is that older nurses, or nurses who had their licenses for more than 30 years, were more enthusiastic in general about open notes, and they were more likely to be encouraging patients to read notes. So over 40% of them had reported that they were encouraging patients to read notes, whereas the nurses who had their licenses for a shorter amount of time, maybe about 30% of them were encouraging patients to read notes. Many of them reported that they changed the way they were writing their notes. They were reporting less use of language that could be perceived as critical. They were also changing how they documented mental health issues or other sensitive issues in the notes. So this is a summary of some of their open-ended responses. So out of the 193, 56 wrote about impacts on patients, both positive and negative. And I'll give you some examples of some of the comments they made in just a moment. 26 of them wrote that patients had reported important errors to them. And a smaller number in the text answers reported specific ways that they changed how they wrote their notes. 5 identified instances where they felt that care might have been compromised as a result of patients reading their notes. And there were a number of other additional comments. So just to give you an example of some of the positive themes, we did a qualitative data analysis of these open-ended questions and identified themes that came across. So some of the positive themes, people made comments indicating they felt that open notes resulted in better patient engagement. They actually they're quoted as saying patients who read their notes were more engaged. They also used terms that it opened dialogue in conversations with their patients. Several reported that they felt reading notes was helping patients to remember what to do from the visit that they had. Patients often forgot what the providers were suggesting in the visit, and when they were reviewed with the patient, they seemed to be better able to remember what the plan of care was. And this particular nurse had said she suggested that they be sure to look at their progress notes. Another comment, they can read the information later in case they miss something. And that's really the crux of OpenNotes, because so often in patient visits, they get so much information, they have information overload, and reading the notes later when they can quietly reflect on what happened in the visit, they often remember things that they hadn't been thinking about. Another comment was that nurses are mindful of the fact that patients are reading their notes. And when they're writing, when they're documenting, they have in the back of their minds that the patients are able to read their notes, which is a positive thing. It makes it even a better tool for communication in those circumstances. We also had a number of comments that were more negative. One of the concerns was that because patients were reading the notes and nurses and other clinicians were being careful about how they write about sensitive topics, including mental health issues, that maybe less information was being relayed and other providers would have less information in reading the progress notes. Another concern was that sometimes patients read the notes and it can make them angry. A nurse commented that frank notes are gone because everybody's afraid to offend the patients. Again, getting back to this issue that if patients are reading the notes, the clinicians are not going to be as honest in the notes and they'll gloss over a lot of details. There's a concern that because details are lacking, that patients will be less adherent, or in this case, the statement was total lack of compliance is sugar-coated to the point of falsehood. So patients that are less adherent, they're less likely to be reporting that in the notes. And there's a concern, of course, of how that might be affecting patient care in general. There's this attitude that came across in some that we classified as paternalism, because there were several that were concerned that giving patients access to their chart was actually dangerous for patients. And they felt that the after visit summaries, which tend to have very little information, sometimes they have progress notes. I'm sure you're all familiar with some of the scant details that are available in the after visit summary. And to compare that with the information that they might get out of a progress note or reading a history and physical note, it's really night and day. But there's a concern that that's too much information for patients. Another common concern is that patients will read things in their notes that will confuse them. And that might also make them less engaged in their care. So in conclusion, from this particular survey that we did, we felt that nurses in general had positive attitudes, but of course they still have a number of concerns. We were concerned that only 1 in 3 of the respondents to the survey had reported that they had encouraged patients to read their visit notes, even though they had these generally positive ideas about OpenNotes. And we concluded from this that there really is more work to be done in educating nurses about the value and the benefits of OpenNotes for patients, in hopes that they'll be more encouraging to patients to be reading these notes. So some ideas to think about for the future: policies and procedures would need to be made for any possible amendments to the notes, because at this point, we don't make changes to the notes, and we may have over time, as patients become more engaged, they may be making more requests for specific changes to the notes. Patients need to be educated about reading notes and understanding how to read their notes and understanding the material in their notes. Nurses could sit down with patients and review the notes with them and answer questions. We still need to understand how best to handle sensitive information, so more work needs to be done. We've done quite a bit of work about mental health notes, and that's available on the website, which I'll be showing you in a minute. There also needs to be more training for nurses in general. You know, that we're right on the cusp of having all the notes be available, so it's going to become more and more important to have training for the nurses so they understand, first of all, that it's not a dreadful thing for patients, that patients are very happy to be able to read their notes. And it doesn't cause more worry or concern for patients. So what are some of the tips that we've learned that we're disseminating about advising providers when their patients are able to read their notes? What is important? It's very important, of course, to be clear and succinct and to be direct and respectfully addressing the concerns that the patients raise in the visit. Because we do know from reports from patients that they get upset if they've talked about something that was meaningful to them in the visit and then they read the visit note and there's nothing about it. So it's important and respectful to the patient to be sure that their concerns are addressed. And using supportive language wherever possible, thinking of notes as a tool for communication, it's also an opportunity for providers to use motivational language with patients, especially if a patient is struggling with the treatment plan for whatever reason. It's an opportunity in the note to point out positive behaviors that the patient has had and to encourage them to continue to work on particular issues around chronic disease management, for example. It's also important to get patients involved in note writing. And patients sometimes are concerned when they're sitting in the doctor's office or in the nurse's office and they see that someone is typing on the keyboard and they're not able to see what they're typing. And patients have reported that this is sometimes distressing to them. Some patients are not bothered by it at all, but others are bothered by it. And it's a time when a provider could say to the patient, you know, I want to be sure that I get this right. Do you want to say exactly what you would like me to put in here? And it's possible then to have a dialogue about what's important about care for the patient and what's important to the provider. And then, of course, as we've been talking about, encouraging patients to read their notes is important and asking them for feedback. And lastly, it'll be very important for clinicians to become familiar with a process for amending notes. If patients demand that something be changed, if they find errors in their notes and they want something to be changed. So I'm going to take a minute and show you the OpenNotes website. We have tremendous amount of information on the OpenNotes website. And we have many webinars and training opportunities. We also have webinars that are recorded. But just to show you, this is the landing page, and it's www.opennotes.org. And it has quite a bit of information about ongoing programs. We have online, quote unquote, drop-in clinics for providers where we're covering different topics. In the next week, I guess that's 2 weeks from now, we'll be having these drop-in clinics with a different topic each day. So I would encourage you, if you're interested in learning more about any of these topics, to be sure and go online and check out the website. We're going to be having a case study webinar on March 23rd on the experiences at the University of California, San Diego, at their health center or at their medical center on using open inpatient notes. So that's sure to be very informative, and that's an area that we certainly all need to be learning more about. We have a number of other webinars coming up and lots of information on here. We also have under this bullet for healthcare professionals, we have several webinars that have already taken place that are recorded. I'm going to show you here. You can just go to all the webinars and there's just tremendous information from webinars that have happened in the past year, even longer than the past year. Cancer notes, pediatrics, many, many different topics. So there's been, and the issue of sharing mental health notes, there's really been some great work done in that area. So just as an example, These are just some of the webinars that are coming down the road and readily available. So that sums up our presentation. I'm going to stop the screen share and we'll have time for questions and conversation about OpenNotes.
But before we get started, I just want to say thank you very much for a very interesting presentation. And I thought I could at least kick off the conversation. I see that you have the open inpatient notes, so it looks like a slightly different product line. But I wonder, since many of the organizations have already implemented OpenNotes in the acute care setting, if you had any experience or anecdotes that you care to share about those experiences that have come your way.
We have almost no experience. There were a couple of institutions in the Midwest that tried open inpatient notes for short periods of time and wrote small papers about the pilots, but they were very well. For example, they did things like print out the notes once a day on paper and give it to the families. You know, the audience for inpatient notes, we think, is families rather than probably patients most of the time. And we know very little. I, for one, I'm going to be the first one there at that webinar next week about this experience in San Diego. I'm really hoping that there are some people on this in this meeting who have already have some experience with open inpatient notes. Is that possibly?
That's helpful. I wonder if someone else on the group might be willing to share their experiences so far. I think the Brigham has gone live. I think Boston Children's has gone live. I wonder if anybody cares to share some things you might be seeing already as best practices, or things that you know are issues that we'll be addressing in the near term.
Hi, Mary. Suzanne Bain at the Brigham. Hey, so we turned on our OpenNotes, I think it was back in, I can't remember now, October or November, for all clinicians and opened all the notes. The biggest feedback we get from staff is concern about particularly like an assaultive or difficult patient, how to write the note in a manner that is direct and doesn't have judgment. The nurse does have an opportunity in the record when they write a progress note to not share the note if they deem that there would be danger to either themselves or the patient. That's been a very big hot topic since it's gone live back then, but my colleagues might, we haven't heard much feedback about the positive right yet. We only hear the questions about the challenging patients. And we've tried to send out some tip sheets with things about, we did do a launch as a enterprise-wide on how to write a note and avoid, abbreviations like SOB. People don't think of that as shortness of breath. They think of it as something else. But I think we're in the learning phases, I would describe it as, but my other MGB colleagues might have other feedback too.
Thanks, Anne. Anne, would you be willing to share those tips?
Sure. Yes, I can send them to you.
Thanks.
Mary, this is Paula. On top of what Anne says, we know from our HIM folks that there really have been very few requests for chart correction, at least from the inpatient side. I believe there's been a moderate amount from the ambulatory world, from the ambulatory practices, but we haven't found thus far that there have been a lot of requests to correct documentation within a chart.
I have a question. Has it been turned on in the emergency room, or is this just in the acute care setting, in the inpatient side?
It's in the emergency room. Certain components of the emergency visit are viewable by patients, not every element.
What about concerns about nurse safety? Because I know internally in our organization, we've talked a little bit about that. I wonder if someone could comment on that. And I mean, from the perspective of the visibility of the nurse's name and licensure, et cetera.
Yeah, Mary, this is Deb from the Brigham, and we have heard that the nurses have felt that they needed to block the note because they feel like that the patient would be able to look up their name you know, could potentially, you know, do something adverse to them. So we have heard that as well. And if it's warranted, then we certainly, you know, guide them to, if you feel like you would be at harm, then you certainly could block the note. But the other thing we've heard is they have concerns with, one example we heard was from the women's health area, that a partner was looking over the patient's shoulder and reading that note about maybe something about their relationship, that they thought that it was not appropriate for him to be viewing that. And of course, he really wasn't signed on as a proxy to be able to access it, but he was just, and I don't, Jan and Suzanne, in the Mass General Brigham healthcare system, which is formerly Partners, all of the system shares the same Epic features. And now we have the MyChart Mobile, so they can be on their phone and looking at a note that was entered 2 minutes ago. So they're seeing it immediately. So there was, so sometimes there are concerns that, you know, they're seeing behavior of, you know, partners maybe that were considered, you know, maybe there's some domestic violence there that was, and maybe the social worker documented it. And then they were concerned that there may be some retaliation with the wife or whatever. So those are some of the anecdotal things we're seeing. And I think we're also kind of seeing what you've seen in your research, that they are not as descriptive in their notes. They're keeping them very vanilla because they're concerned that that the patients are able to read them.
And, you know, the other comment just to add to Deb's thoughts there, that we were actually able to run a report for like, I think the last 2 quarters or the last 2 months to see how often a nurse actually did block the note. And surprisingly, the number was very low. We expected to see more of that. And then the only other area too, I hear a lot about from oncology, because there used to be an embargo on some certain lab results, like path results, and those kind of very difficult things. So they're getting a lot of calls from patients because they oftentimes see the results before the provider can actually talk to them about that. And there's been a lot of asked, like, can that go back? Because the provider feels like they don't have a chance to actually explain what the results mean, and it can lead to some very heightened anxiety. But from what we understood in the law, that's not considered, emotional distress was not considered significant harm to be able to hold back the information.
I heard an interesting conversation last week and a presentation by an attorney about this, who pointed out that there's nothing in the rule or the law that defines quote unquote immediate. And he thinks that one of the things that's going on is that institutions are all trying to decide what is soon enough for certain tests. And it felt like this is one of the things that's going to evolve as this thing rolls out.
Yeah, we made it immediate at MGB. So everything is immediate. And because we have, you know, the partners thing is MyChart bedside, or they can look it up, just as Deb said, right from the bedside, or the family in California can look up the mother's results before the care team has been able to deal with that. So those are kind of some of our challenges, but otherwise it's pretty much, so I'm from the North Shore part of MGB, and it's pretty much what you've already described. So, and we had some interesting things with the patients complaining about, they didn't like that their records were going to the Massachusetts immunization registry, even though that really had nothing to do with us. So some little anecdotal things like that, but.
Yeah.
Diane, this is Paula. So I'm curious if you've gotten any feedback from your behavioral health areas, because our behavioral health content also has gone live in terms of nursing notes.
Yeah. Ours did. We have we're 120 beds behavioral health, and actually no comments from them at all, which is interesting.
Really?
So, and we did go live with them.
Yeah, I do know there was a lot of emphasis on how they how they should write their notes to make it as objective as possible instead of subjective. But I think they were already good at documenting in that frame of mind to begin with.
I totally agree with that. And so our executive director there was like, you know what, listen, today they can just ask. They can ask for their chart immediately and sit down and read it. So this is not new for us. So they did not feel threatened by that. So yeah, that was not as much an issue. We have a couple of units where nurses, just by nature, that they have a lot of young, pretty nurses, and there's been some kind of stalking of those nurses by patients where they've had their pictures taken. And so they were expressing kind of some of what Deb said, where they didn't want their last names out there. They didn't want, even though this is all, they could have always gone and, retrieved their record and looked that up if they had wanted to. But so those were concerns more in the beginning, but we haven't actually found that to be happening. So, but we do have a lot of violence at the North Shore, primarily in the ED.
I have a question. Well, how about any of our friends from Maine, Rhode Island, Connecticut? Anybody have anything to share yet?
Hi, it's Barbara Jones.
Hi, Barbara.
Here in New England, in Rhode Island, just listening to all the folks who have gone before us, because we're opening up as of April 5th, but it's good to see the folks who've already done it. And I think what I hear is a lot of the fears that are being expressed don't come to fruition, if I'm hearing correctly. That there's been more positive than negative. So that's great feedback that I can take back to Care New England.
Hi, this is Martha from Maine. I know that our Maine health system is actually going to OpenNotes very shortly. So I have a colleague that is keeping the pulse on that. So I'll keep you guys updated, see how it goes.
Mary, this is Kathy McDonough
Hi,
from
this is
BIDMC. I had a NICU nurse call me recently that the parent was at home reading the chart and calling the nurse frequently throughout the shift on everything that was written in the chart, like multiple times, very aggressive and very angry and asking questions.
It's interesting. It's very interesting. I was wondering also, are there more is there more rounding? Are people saying, well, we're going to, so much communication used to happen in the chart. Are people moving to more verbal rounds, or are they becoming more important for the more sensitive information?
I don't think the behavior has changed from that regard.
Mm-hmm.
I do think people have learned how to write sensitive notes in different ways. So for example, because we have a behavioral health unit, sometimes they have to be taken to court. A lot of discussion occurs around that possibility of needing to go to court, to whether to get guardianship or put them in a different section. And those patients are often not told until the day of their court appearance. And so those notes now go into some category that's considered sensitive that isn't released in an open note type of fashion.
Interesting. Hey, Kathy, back to you. I think just so, does that nurse have any recourse, or is there support for that individual? Because I could see that escalating.
Yeah, well, they had to talk to the manager and the physician to try to put limits on calls, and it was a baby who was sick, so she was questioning everything they did. So it was really difficult and tough for the nurse to come out of the room.
Yeah.
But they had to put limits on that. They'd call her once a day and give her an update.
Yeah.
But it was very difficult for the nurse and for all the staff.
This is Mary Suzanne. I'm from Trinity Health in New England. This was a wonderful conference tonight. I found that, a lot of the open note concepts, it's focused around providers, not necessarily nursing, respiratory, and the other folks that get involved with this. So it's nice to hear that everybody's just as concerned about the information that we document.
I will say in the this large clinician survey we did, and it's published, the nurses were not that different from everybody else, the doctors, the pharmacists, the nurse practitioners, etc.
That is good to know. Any other comments or feedback from your recent experiences?
I noticed comments and questions in the chat.
Oh, let's see. Sorry about that. I must have missed some. This one from Nancy Giacomosi. Do you track and audit the notes that are blocked to make sure that people are not blocking notes inappropriately? Jan, do you want to take that?
You know, I don't know what people are doing. All I know is that not many people have been blocked.
Mhm.
I don't know.
Okay.
Hey,
Anybody else?
They are.
Mary, this is Sue Whetstone. How are you?
Hi, Sue.
We are doing something. I know we're starting to do some tracking, so I don't have any strong data I can tell you yet, but I can tell you that when we went live back around the October, November timeframe as well. And initially we were relying on people having to know to enter in a smart phrase to put in the reason for that note. But thankfully, Epic has upgraded the software. So now that we can make it a mandatory field. If you say you're not going to share it, we can capture those reasons. So we'll be able to use that to try to do some analysis of why. But again, in general, people are sharing, but there is a subset. And that's what they're going to be looking to, is like trends. Is it certain providers? Is it nurses more than physicians? Is it a certain practice within physician group, et cetera? So we'll be looking at that to try to get a sense.
Thanks, Sue. It's good to know.
Could I ask a question of Suzanne?
Please.
When you were going over your slides, there was one of them said from the Clinician Concerns slide that 1/3 of respondents said that they felt like there was an increase of documentation time. I was just curious, Mike, I can't imagine there was a decrease in any of them. So was the 2/3 essentially saying it stayed about the same, or was there a smaller subset of people that actually with this saw improved documentation time?
Suzanne, do you remember the number?
Yeah, I think the vast majority said it was the same.
Yeah.
It really didn't have much of an impact, but there was about 1/3 that had commented that it took them a little bit longer. But we didn't get a lot in the text that they were stating that this was really creating a big burden. I think for most of them, it was a matter of adjusting to writing a little bit differently, because so many of them did report that they had to, about half of them reported that they changed the way they were writing some things. So they took a little bit longer, but once they got the hang of it, it really didn't seem to be a big burden.
Thanks. Any other closing questions? Well, if no other questions, then I want to thank you very much for your presentation tonight. I think that it would be almost nice if we could have a follow-up presentation in a couple of months, because I think there'll be a lot of experiences about, especially in the inpatient area. But, it's certainly wonderful to have the foundation that you've set in the outpatient area and to have some quantitative information to bring back to our community so people can share best experiences so far. And I'm sure we're going to have a lot more information as we go forward. But I really liked your statement when you said, why not treat the medical record like an ATM? It's your information. Which historically, I think that's not always been clear. Sometimes the organization thinks it's their information, and there's been that conflict historically, which is important to put into context. But thank you very much for your time and the presentation to this evening. And thank you to everybody else who participated. It's wonderful to see everybody virtually until we can meet again in person.